already. So now that it's recording, again, I deeply appreciate y'all being here, both virtually and then those watching the recording. Thank you for being there. I see y'all too. The title of my dissertation proposal is Birthing While Black, a qualitative exploration into the experiences and implications of the COVID-19 pandemic on Black maternal health and care. So before we get started, I just wanted to begin with some inclusivity considerations, because I recognize that some people who become pregnant and give birth do not identify as cisgender women solely. So in this presentation, the terms women, mothers, and pregnant capable people and pregnant or birthing persons are used synonymously in an attempt to account for all people who seek any reproductive, preconception, prenatal, birthing, and postpartum care. All right, so the goal of this proposed presentation and dissertation project is to better understand how Black pregnant women and people conceptualize their own physiological and emotional experiences of stress, coping, and social support throughout their perinatal period in the context of living through the COVID-19 pandemic, as well as here in Texas. All right, so a general overview of my presentation here today is we'll talk through the health disparities of the COVID-19 pandemic and its effects on vulnerable communities, as Black communities in general, and then Black pregnant capable people specifically. We'll shift to the Black reproductive and mental health crisis by talking about the adverse maternal health outcomes and the care that's associated with addressing them. And then lastly, we'll go through the proposed dissertation study and talk through the research questions, theoretical framework driving the study, and the qualitative methodology that will be being used. All right, so for the health disparities of the COVID-19 pandemic and its effects through the vulnerable communities, we can recall that during the early stages of the COVID-19 pandemic, there was this increased concern that mortality rates and virus infections were inequitably distributed among vulnerable populations. And so you'll see that the communities of people who are considered the most susceptible to death and loss throughout this quality of life throughout this pandemic are here listed on the screen. But for this study, I'll have a primary focus on Black pregnant communities, but also the intersecting dynamics along with how these individuals on the screen may be naturally linked to pregnant communities within the Black community. So historically, underserved racial ethnic groups have often experienced vulnerabilities and social inequities in health due to long-standing structural racism, segregation, and discrimination and marginalization as all around treatment as well. And during the pandemic, these underlying factors have contributed to higher risks for exposure, transmission, infection, and then death among Black people in communities. And you'll see that these implications of the COVID-19 have that increased number of deaths and overrepresentation among Black people being hospitalized as well with COVID-19 compared to other races. And given these implications of the pandemic on Black communities, it's essential that Black women are carefully considered, because before the pandemic, many Black women experienced a variety of hardships. So these were due to balancing various responsibilities such as financial commitments, anything that had to do with caring for extended family or childcare, if that was applicable, and then general community service roles. And these are all things that were leading to adverse health outcomes related to acute and chronic stressors, as well as chronic conditions. And due to these stressors on the body, the emergence of the pandemic, Black women are more likely to suffer from these pre-existing chronic health conditions like your type 2 diabetes, obesity, and asthma, but also to live in higher density areas and cities where social distancing and self-isolation are just not as feasible. And these are all conditions that can increase their susceptibility to COVID-19 exposure that did increase at the time as well, and they related morbidities and mortality. And so given these rates and considering within the adverse maternal health outcomes, these disparities have naturally posed the greatest threat to Black mothers. So for studies like this that I'm doing and further research, it will require attention to this complex intersectionality of pregnancy, gender and sexual expression, race and ethnicity, socioeconomic status, but also how other structural inequalities have been magnified in the COVID-19 era, especially this era that will follow. All right, so we will shift over to the scope of adverse maternal health outcomes and discuss maternal mortality, maternal morbidity, as well as maternal mental health. So first, for maternal mortality, a maternal death is defined by the death of a woman or person while pregnant or within 42 days of termination of that pregnancy. So this can be from any cause that's related to or aggravated by the pregnancy or its management. And in the US, every single year, approximately 700 women die from pregnancy-related causes during pregnancy, during the birth-giving period, or within a year postpartum. Black pregnant people are 243% more likely to die from pregnancy or childbirth-related causes. And this is a rate that's 3 to 4 times higher than any other rate, any other racial group. And you'll see in this chart that was conducted through the CDC from 2018 to 2020, that when reporting for race-based maternal mortality outcomes, this general rise that we're seeing in the overall mortality rates between 2018 and 2020, here at the bottom left, that this rise can be explained by the escalated rates that we're noticing for Hispanic Latinas all the way to the right in the dark blue, as well as for Black women who are here right in the center. So notice that for Black pregnant women and people, they had the highest maternal mortality rate across all racial or ethnic groups at 55.3 deaths for every 100,000 live births. And like I said, this rate is 3 to 4 times that of other racial groups, such as non-Hispanic white women at 19.1 deaths per 100,000 live births, and then 18.2 for Hispanic Latinas for 100,000 live births. And these discrepancies, although we see that for Hispanic Latinas, that difference between 2019 and 2020, which was the first year of the pandemic, these discrepancies between non-Hispanic Black and the other racial groups currently represents the largest disparity among all conventional population perinatal health measures. And in addition to these rates of maternal mortality, there was also a shift and an increase across multiple age groups within these Black communities, and where those who were above the age of 25 were more at risk of experiencing maternal death or morbidities, but especially between the ages of 35 and 40. All right. So these figures also, I wanted to bring note to that, although these figures don't show or delineate whether deaths occurred in connection with a COVID-19 infection, they do come amid a concern about how the indirect and direct health risks of the pandemic has posed for pregnant women and people. All right, so we are now at the maternal morbidity or severe maternal morbidity, SMM. And the CDC defines a severe maternal morbidity as an unexpected outcome that is from or through labor and delivery that results in a significant short-term or long-term consequence to a birthing person's health. And in the US, for every 1 maternal death, it's equivalent to about 100 pregnant capable people who have just given birth suffering from a severe maternal morbidity complication. And this can roughly be around 60,000 to 65,000 per year. And this involves potentially receiving a life-threatening diagnosis and will include a medical intervention that requires a delivery-based procedure and a hospitalization stay. And prior to the COVID-19 pandemic, Black pregnant women and people have disproportionately experienced higher mortality rates due to very specific and preventable severe maternal morbidity complications. And these are such as preeclampsia and eclampsia, which have to do with hypertensive disorders, blood pressure elevated, cardiomyopathy having to do with the heart, gestational diabetes with elevated blood sugars. We have placenta abruptions having to do with the womb and the uterus, and then postpartum hemorrhaging, which involves excessive bleeding after giving birth as well. And so, for example, there was a study by Howell back in 2018, so of course pre-pandemic, that in the US found that about 75%, so the majority of Black deliveries, 75%, they were occurring within a condensed area and a set number of hospitals that had the highest rates of severe maternal morbidity complications and outcomes, whereas white deliveries were only 18% as likely to occur in those exact same set of hospitals. And so this sheds light on the fact that the labor and delivery care that Black patients tend to receive in hospital settings has historically led to lower rates of effective medical intervention treatments, and then higher rates of mortality and severe maternal morbidity complications when compared to other racial groups. And these structural inequalities for Black mothers in the healthcare system are then profoundly exacerbated for those who identify as non-traditional Black pregnant capable people. These could be known as Black queer and trans birthing parents, Black surrogates, Black undocumented mothers, and then also those who fall outside of these categories as well. And for the last piece for the adverse maternal outcomes is maternal mental health. And we know that maternal or mental health as its own category is an essential general health indicator that is applicable to every phase of an individual's life. But for expecting mothers, any adverse mental health conditions that are present prior to conception can have serious implications for prenatal and postpartum health outcomes. And although racial disparities within maternal health can predate COVID-19, this current pandemic has widened the gap of mental health care accessibility and referral, mental health disorder screening, as well as an individual's readiness to initiate maternal or mental health care treatment. So despite the enhancement and progression of virtual platforms and telehealth care services, all pregnant people are at an increased risk for experiences of worry, loneliness, and isolation within hospital and other perinatal care settings. But due to the COVID-19 pandemic, and given the histories of healthcare related barriers such as provider communication, perceived racial discrimination, and medical mistrust, Black pregnant people are particularly vulnerable to psychological distress during pregnancy-related caregiving. And we'll see for Black pregnant people in Texas, they've had the highest rate in symptoms for both prenatal depression at 21.1% and postpartum depression at 23.0%, compared to other racial ethnic groups of mothers for both prenatal depression and postpartum depressive symptoms. But given the nature of mental health and culture as a whole, these areas and these differences in these percentages that we're seeing can be multifactorial and complex, and also very interrelated, especially when it comes to appropriately addressing them. So how have these reproductive and maternal health outcomes been addressed over time? We have preconception care and prenatal care, and then delivery and postpartum care as some of the most known options. So preconception care and prenatal care linked to a variety of adverse perinatal health outcomes. Nearly 1/2 of pregnancies are unintended, and Black pregnant people experience 2 times the rate of unintended pregnancies compared with other racial group outcomes. And this discrepancy has then led to a lower engagement with, adherence to, and access to prenatal care visits, where Black pregnant people have been 4 times more likely to attend only 0 to 5 prenatal care visits. And to put this into context, this prenatal period spans from week 0 to week 40, which is not that 9 months of pregnancy. And that's if fortunate enough and applicable and safely able to carry to full term, of course. But when we think about preconception counseling and early prenatal care visits, these can play an essential role in utilizing clinical health resources prior to pregnancy, but then also lead to early identification of adverse maternal health risk factors and genetic dispositions, such as from tobacco use or genetic dispositions towards chronic conditions like type 2 diabetes and hypertensive disorders and obesity. But these utilization rates in these prenatal care visits sheds light on the present disparities that are within the relationship between prenatal care visits and then increased susceptibility to adverse pregnancy outcomes. And you'll see those listed, such as infant mortality, maternal mortality and morbidity, low birth weight, and preterm birth. However, these active participation rates in prenatal care visits among Black pregnant women and people, they're not just a matter of choice, or they're not just a matter of whether these individuals are choosing not to engage, but these can be explained by social factors such as discrimination and psychological distress when within healthcare settings, as well as healthcare insurance, access to transportation, and other elements that serve as barriers to prenatal care. Therefore, these types of complex factors may serve a critical role in this further explanation in the health and racial disparities across also labor and delivery experiences and postpartum care treatments. All right, so now with these delivery and postpartum care, we can recall with the study that I just mentioned with Howell in 2018, where Black deliveries that were occurring within that condensed area and set up hospitals with the highest rates of severe maternal morbidity, that the results of this study highlight how hospitals that disproportionately cared for Black deliveries had higher risk-adjusted rates of severe adverse maternal outcomes as a whole for both their Black mothers and their white mothers who were delivering at these same hospitals. Oops. All right. And then following a delivery is this postpartum period. So that can span within 1 hour after giving birth, as well as all the way through 6 weeks post-delivery. And that's these visits, these postpartum care visits are an essential component to monitoring the health of Black women and Black pregnant capable people who have just given birth, who either have a pre-existing chronic condition or a now pregnancy-related chronic condition. And these mothers are facing these types of existing barriers, like I mentioned again with the prenatal care, when it comes to accessing postpartum care, such as the healthcare insurance, the effective and supported communication with their providers, transportation, newly developed childcare costs, and then psychological distress due to the care and the treatment that they receive in these healthcare settings or hospital type settings. So, and although this postpartum period may present a pivotal point for intervening and addressing the health and well-being of these women and people, these postpartum care visits and retention levels still remain low for historically marginalized and low-income mothers. So this sheds light on the importance of birthing environments and then how places matter. And in order to reduce the rates of these adverse maternal health outcomes and disparities in the healthcare settings, critical attention needs to be aimed at the quality of care during these pregnancy-related caregiving spaces. So now we are at the overview of this proposed dissertation study, and just to put it at the forefront of our minds again, that the goal of this proposed dissertation is to better understand how Black pregnant people have conceptualized their own physiological and emotional experiences of stress, coping, and support through their perinatal period in the context of the COVID-19 pandemic while living in Texas. And we'll talk through the research questions, the theoretical framework, and the qualitative methodology. So the research questions that are guiding this proposed study starts with this overall general question of what are the pregnancy and birthing experiences of Black pregnant capable people in Texas during the COVID-19 pandemic. Study 1 will focus on the pregnancy and prenatal care experiences of these individuals, where study 2 will look at the birthing and postpartum care experiences of these individuals. But I will start with the theoretical framework that will be utilized to carry out the design and the data analysis of these studies, which is the stress process model. And that image is a little bit hard to see, but the overall, what to get through this is that this was a stress process model that was developed back in 1981 by Leonard Perlin, and it was developed to address the shortcomings of the acute stress process and its effects on primarily depressive symptoms. But this resulted in a primary focus on examining the effects of the specific challenging and traumatic life events. And further research was able to find that this lacked a consideration for subjective chronic assessments over time, as well as incorporating an individual's social circumstances and characteristics when thinking through health outcomes that are beyond just a single mental health outcome indicator like depression or depressive symptoms. Therefore, there have been recent developments of the stress process model, and these types of models now are reflecting a shift towards examining general health by including assessments of chronic stress factors and social factors or social characteristics as key determinants to the heightened stress exposure or determinants to heightened stress exposures. And so these crucial shifts we'll see through Turner back in 2013 with this health disparity driven stress process model now can make it clear that the health disparity outcomes that are associated with the stress process can stem from socially determined and preventable sources. And so to make it, just to tie it in with explaining just a couple of these variables of the model, social characteristics have like sex and gender expression, race, ethnicity, socioeconomic status, and other elements that fall within that, like educational level and so on, can have an influence on one's quality of social resources, one's developed personal resources, and then the nature of the stress exposures. So the social resources refers to the quality of an individual's personal relationships, like their social support and their social network. Then personal resources refers to psychological protective qualities, like your sense of control and mastery, self-esteem, emotional reliance, and mattering. And then finally, the nature of one's stress exposures can be exacerbated by one's social characteristics and lead to adverse general health outcomes. And these, similar to the purposes of my research in this study, exploratory studies by Turner have displayed how those who belong to historically discriminated and marginalized groups are subjected to increased experiences of adverse physical health outcomes like compromised immune systems, elevated blood sugar, blood pressure, and cholesterol or excess weight gain, as well as adverse mental health outcomes like psychological distress, anxiety, and depression or depressive symptoms. And then next we'll talk through how all of this comes together within the qualitative methodology I'll be using. And so I'll utilize a descriptive design, which is a well-trusted qualitative inquiry that allows for subjective experiences and interpretations for the given phenomenon by bringing in participants, researchers, and then pre-existing literature that surrounds these types of research questions that I'm asking. And this type of study design is especially useful for research that involves participant and patient healthcare treatment, utilization, and interventions, and really brings to the forefront their stories and personal experiences within those healthcare settings. All right, so in order to follow this type of design, I have my inclusion criteria for those who qualify for this study. Will identify as above the age of 18 years old, but identify as a cisgender woman or pregnant capable person, a Black or African American or mixed with Black or African American. They are or were pregnant anytime between March of 2020, which was the onset of the COVID-19 pandemic, and the present, and then currently live or previously resided in Texas during their pregnancy or birth-giving period. Now, given the descriptive qualitative design of this study, 16 participant interviews would be sufficient for reaching like 90% of saturation among this population's experience. But for this study, it's a key component of this study is to gather experiences from various aspects of the pregnancy and birth-giving periods, as well as identities among these Black birthing capable people in Texas. Therefore, in order to achieve this type of saturation along this range of experiences possible, I have that number set at 30 individuals. Now, the recruiting process procedure, just in terms of who I will be working with, are lovely Texas-based communities and organizations. Hi to those who are watching. And I'm just so appreciative to be able to work with them because of the communication that they all have as a Black maternal health community, as well as equity and different types of ways to address the health disparities in Texas going on now that we are in this post very interesting phase of the pandemic. But that involves things like universities like UT here in Austin, city public health offices in the major cities in Texas, especially here in Austin, and then maternal health groups that have a primary focus on Black maternal health and Black congregations and church communities in order to access and be able to work with a lot of these women who would qualify, women and people who would qualify for this study. Next, we have an online questionnaire that will consist of sociodemographics, talking through race, ethnicity, age, sex, gender expression, but also educational level, employment status, household income, and then gathering pregnancy history and birth-giving histories. And then it will also include a perceived discrimination scale, perceived medical trust scale, and 60 to 90-minute interview will be the basis of the majority of my data collection. And these interviews will be guided by the stress process models components like we just discussed, but also interweave the differences between their experiences of prenatal care and their postpartum care visits. And then finally, the data analysis plan will follow a qualitative descriptive study design that has both a directed content analysis as wave 1 and thematic analysis of narratives as wave 2 over the data sets. So this is an overview of the data analysis plan for the proposed project. And you'll see that while the general lived experiences of Black reproductive and maternal health during the pandemic will be gathered for both studies, the lens for the data analysis process will differ based off of the research questions for each study and undergo 2 waves of analysis like I just mentioned. So to answer the first research question, study 1, wave 1 will follow a directed content analysis in order to generate initial codes, identify evidence of the stress process model's variables within the scope of reproductive health histories and prenatal care experiences. And then study 1, wave 2 will follow a thematic analysis of narratives and explore the stories being shared and shed insight on the subjective qualities of the data within the scope of, again, reproductive health histories and prenatal care visits and experiences. And now to answer the second research question for this study, study 2 will follow a very similar data analysis procedure as study 1, but with the lens of birthing, delivery, and postpartum care treatment. So wave 1 will do that same directed content analysis by generating codes and evidence of the stress process models and variables within that data. And then wave 2 for study 2 will explore the stories being shared, the subjective qualities of the data, but again, all in the context of birthing, delivery, and postpartum care treatment. And to break down the importance of conducting both waves and methods of interpreting this data is that wave 1's directed content analysis for both studies will involve quantifying the qualitative data that's going to be collected, such as like frequency of codes, as well as aligning the data with the existing variables of the stress process model and the relationships between them. Whereas wave 2's thematic analysis of narratives for both studies will allow for a higher level interpretation of themes related to the core of the phenomenon, which is where power truly is in terms of this type of study, because now meaningful implications for further intervention and practices can be found in those stories. And this will involve locating outlier stories, missing variables, and additional variables to the existing theory, along with highlighting novel experiences that will contribute to adjusted developments of this stress process model in regards to better understanding the maternal health crisis at hand. All right, and then for this last piece is in order to ensure internal and external validity of the results for this dissertation project, I'll be utilizing Lincoln and Goba's validity assessment for qualitative findings. And so to meet credibility and confirmability, I'll utilize member checking, which involves bringing in research participants and community stakeholders like our Black maternal health groups, and sharing the study findings with them and being able to discuss that with all those who are involved in that process. And then transferability and dependability will be met by having a transparency in the documentation of this process, such as the literature review, methods of the data collection and analysis, along with the audit trails and journaling throughout this data analysis process. And then the triangulation of data will be met by collecting data from multiple sources for analysis. So like I mentioned, the socio-demographic survey measures and the items within that, the interview that are individual per participant, as well as participant observations, and utilizing field notes in order to inform the findings of this type of study. So that brings us to the end of this presentation. And I just want to finish off with just this idea that collecting these lived experiences of Black mothers is critical to understanding how to address the lingering effects of the COVID-19 pandemic on the maternal health disparities as we move forward. So every single time someone who is Black and pregnant feels ignored or unheard or alone, it creates this window into how care is being perceived both emotionally and physically, but also how methods of practice and treatment can be improved. And that is the sole purpose that's driving this study. And thank you so much. Happy Black Maternal Health Week. And I hope I can answer any kind of questions that you all may have at this point.
Thank you so much, Jaylen. What an excellent and really important topic and presentation, so thank you. So at this point, we will open up for questions for Jaylen from the audience, and committee members we will meet afterwards. So feel free to unmute or type your questions in the chat. Go ahead.
Sorry, I'm breathing.
I have a question.
Yes. Hi.
Yes. Hello. First of all, great presentation. Like what said, it's very important, especially during this week. Good awareness. It's a huge disparity amongst this group, so I'm really amazed of what your proposal is intended to do. My question is, for your you mentioned your inclusion criteria. I was curious if you will be including Black mothers who were expecting a child, but they experienced a miscarriage in your study.
Absolutely. Thank you so much for that question. And so great to see you. So yes, I have incorporated things like that into my inclusion criteria for this study. As we can recall that anybody who experienced a pregnancy within the time frame of since March of 2020, since the pandemic began, will be qualified for being a participant in this study.
Okay.
And so that way we can include all types of ranges within the experiences of pregnancy, even if they did not result in a birth.
Okay, I love that. Thank you.
I do have a question, if I'm available. Hi, my name is Natalia. Thank you so much for allowing me to participate in this Q&A. I commend you for your amazing study and look forward to learning more about the specific crisis, which is very important. My question is, in addition to the mothers, do you plan on speaking to the medical professionals and specialists like our doctors, our nurses, and even our midwives?
Absolutely. Thank you so much. So great to see you as well. And so I have had a wonderful journey in terms of solidifying this type of research project. But that also involves trying to keep myself sort of calm and knowing that I have time to incorporate so many different types of exciting ways to look at this type of research that's critical and important. But when including mothers, and if you can, let's see, can you remind me that last piece of the question real quick?
Yes, absolutely. In addition to the mothers participating in the study, do you plan on speaking to our medical professionals, like our doctors, nurses, and even our midwives?
Yes, thank you so much. I almost went blank during it. I appreciate the patience. But yeah, so wanting to speak with pretty much anybody and everybody who would be involved with Black maternal health is something that I would love to do for further studies that will complement this type of study, or this type of study will inform those. But at one point, I had the interest in talking with doulas, Black doulas specifically, who are like birthing coaches for these types of mothers who are expecting, as well as midwives, OBGYNs, and physicians, general care physicians, and the nurses that are all involved with Black maternal health and care and those types of patients. But for this study, specifically, I'll just be working with the dynamics of the interpersonal relationships of the Black mothers and expecting mothers, and then their experiences of the working with those types of professionals and they throughout the process of prenatal birthing and postpartum care visits with them.
Thank you so much, Jaylen. I learned a lot today.
Thank you for the question as well.
Jaylen, you have two questions in the chat. One from Rose that said, with such exposure of disparity, do you know of any actions that have taken to hold healthcare providers accountable?
Such exposure of disparity, do you know of any actions that have taken to hold healthcare providers accountable? Now, thank you for that question. And I plan to be able to record all of these and look into them at another time. But my present sort of understanding and way to address that is by talking with the Black maternal healthcare sort of settings within Austin. I have learned so much more about when it comes to holding healthcare providers accountable, how it can differ per state, city, and in the hospitals that have very particular policies that hold their own healthcare providers accountable. But I know that within the Black maternal sphere here in Austin, Texas, what I've been able to come across so far is that that's where we are trying to improve. That's what we are trying to investigate a little bit more, because there's this idea that when we see these, like I mentioned, severe maternal morbidities and complications that are in hospitals that primarily, or that are known to primarily work with Black patients and expecting mothers giving birth, that these rates may be attributed to maybe only one or two or a few doctors that are working with these Black patients, versus that hospital is becoming known for high severe maternal morbidity rates and mortality rates, but it can be the result of maybe one or two doctors, but it's sort of exacerbated for the entirety of either a healthcare setting like in a hospital or within the rates of a actual city and Black maternal health outcomes. So I think that's one piece that I've been receiving as feedback in terms of looking into for both further studies, but also to talk through the perception of, do these Black mothers and expecting mothers feel that their doctors are being held accountable and getting their perspectives on that. So that is a work in progress, if that helps answer the question.
We have a second question here from Peter.
All right, so I'm sorry, I'm just sort of reading it. Please. If you are also going to look at the intersection of your current research questions with the pre and post implementation of the SB 8 here in Texas, especially as it is pertaining to the lived experiences of Black birthing persons, considering that they are the ones most predominantly affected by this law. Yes, so what I, and hope at some point I for anybody who would like to see the type of, and thank you for that question, Peter, who would like to see my sort of interview guide that I plan to utilize for this study, I'm able to ask questions within the interview that get at different types of policies that they are either aware of when it came to their own maternal health and pregnancy and birthing process in the hospitals, and maybe their access within health insurance and things like that that's affecting their labor and delivery process, and how they talk about it. Do they feel that it is being do they feel that these types of like the SV8 is being implemented at their level on a very personal level within the city. So that's why it's a Texas-wide study, and I'll be able to get those perspectives on these types of laws and policies that are being placed and passed at a higher level, but maybe not practiced at the interpersonal level, patient to patient. So I appreciate that question, and I hope that I'll be able to speak to it when I go to present these findings.
Hi, Jaylen.
Hi, Sean.
It is so amazing to see your work and to see this, just to see you grow as a scholar. So I'm just completely fangirling, but I will be very academic and make a comment and a question. And so I'm really glad that you're doing a qualitative methodology in reference to this topic. And I think multiple forms of methodologies are needed, but I'm glad that you are doing a qualitative study. And as somebody who's in the field, who are hearing stories, not similar to yours, but that can be traumatic when dealing with marginalized communities. How are you, I'm really interested in how you're planning on either being reflective through this process. You're probably going to hear, based on the data, just a lot of stuff that may be hard to hear. And so how do you plan on like processing and reflecting and take care of yourself in the process of hearing these maybe very adverse and horrific stories that you could encounter?
Absolutely. Thank you so much, Sean. I appreciate that, my fellow scholar. Yes, so I have been able to work with so many people that have given me that fresh perspective of doing this type of work, whether it's qualitative work in general or just that person-to-person type deep level narrative type work, and have gotten the feedback along how I approach these types of interviews and conversations when it comes to taking care of myself, taking care of my own health and my well-being throughout this process. And so what I have in place, and it is quite the plan, and it's very personal and special, but I am working with my own, I'm comfortable sharing this, I am working with my own mental health counselor throughout this process, who is very well aware of the work that I'm doing, how I'm doing it, when I'm doing it. And I feel comfortable being able to share sort of non-identifiable type information with them, but how I'm processing it. So not in a way that participants would have to feel like they are, like their information is not safe with me, but instead of how I'm processing their stories and lived experiences. The second part of my sort of plan with that is going through these interviews with a very trauma-based approach in how I talk about these experiences, because not only will I be bringing up moments of distress and trauma for them that may potentially, lead to other types of mental health concerns or just things to be aware of, both during the call and off the call or interview, that I am interweaving that very sensitive and considerable approach for the conversations, as well as having a mental health counselor and mental health sort of resources on hand in case any of these individuals I'll be talking to experiencing any type of adverse sort of repercussions from having these types of conversations. But it will be very personable in how I approach these conversations. If that answers, thank you. All right.
Question, Jaylen. Hi. Okay, apologies if I missed this, if you said it, and it might also be outside the scope of things, but just top of mind for me because I'm working in overdose prevention now. But I know you spoke about like mental health and depression and I was just wondering too, if you're going to be gathering data about substance use and maybe like medication for opioid use disorder or any of those kinds of things. Because I guess I'm just thinking about experiences we hear about with stigma in the healthcare system whenever it comes to pregnancy and opioid use disorder, or the different, I guess, ways that people have encounters when they're using substances and involved with the healthcare system, or fear of having children taken away being a concern with the use of substances in pregnancy and things like that too. And just wondering if that was also part of any of this, or if that's outside the scope of this.
Absolutely. And thank you for your question. So great to see you. I want to sort of mention that what you just mentioned is not outside of the scope of this type of study. If anything, it's again interwoven within both prenatal and postpartum care sort of visits, as well as when I think through this general goal of I want to learn more about how these individuals have coped, have felt supported, have in general just processed the different types of stressors that they're experiencing throughout their pregnancy. And substance abuse does fall in within that. Different types of mental health disorders that fall outside of anxiety and depression have a lot to do with this, how we experience stress within the body and how we talk about it. So I will hope that in the analysis piece of this project, that when I'm asking questions about different levels of coping or different sort of sources, resources that they utilize to help cope and receive support in terms of their mental health or physical health, that I can potentially code for anything that has to do with substance abuse or any type of medication treatments that were involved with their healing and overall processing of their experience. Thank you.
Thanks. Great job.
Thank you so much.
Well, thank you for all those wonderful questions. And great job, Jaylen. And so at this point, we're going to ask everybody to hop off so the committee can meet together and meet with Jaylen. So thank you all for coming. And Jaylen, do you want to stop recording?
Oh, I sure do. Thank you.